This session is now live.
Welcome to session number 5 and our last session of the day. Before we get started, I want to say thank you to Carolina Rehabilitation and Surgical Associates for sponsoring this session that helps us take a closer look at behavioral challenges after brain injury. Natalie Forberg is our presenter, and Natalie is a board-certified behavior analyst with Learning Services in Creedmoor. You can read her full bio on the speakers portal. As a reminder, questions are welcome. Please ask them, and they can be added to the Q&A box throughout the session. We hope to have 5 to 10 minutes at the end of the session to address questions from the audience. All right, Natalie, take it away.
Thank you, Dr. Groff. Good afternoon. My name is Natalie Forberg, and I'm a behavior specialist that specializes in neurobehavioral rehabilitation. I am not only a professional, I am also a parent of a brain injury survivor. This is my family after my 11-year-old daughter suffered a severe traumatic brain injury from a bicycle versus motor vehicle accident in 2003. Over the years, she's had many behavioral issues, and I'd like to take this opportunity to share with you some of the strategies that I have learned and employed as both a parent and a professional to address these behaviors. A bit of a disclaimer here. Please note that these strategies and techniques that I bring to you today are for mild to moderate behaviors. Behaviors that are more complex and serious in nature, such as self-injury, extreme physical aggression, etc., as well as behaviors that are resistant to trialed interventions, need to be evaluated by a professional, such as a behavior analyst, a psychologist, or a neuropsychiatrist. The behavioral responses provided today should not be used for severe behaviors and could actually make them worse. So please keep in mind that these are for mild to moderate behaviors at best. We will talk about this again, not only to serve as a reminder, but to reiterate its importance. Today, I'm hoping to provide you with some useful information about behavior management after brain injury. We'll start with some common behaviors seen after brain injury. Then we'll target pinpointing and assessing problematic behaviors and learn strategies to not only extinguish or decrease behavior, but also talk about strategies to prevent a behavior from occurring in the first place. I am most definitely interested in answering your questions, as I love to talk about behavior. However, my self-diagnosed ADHD would get me off task, and I would never be able to get back on. So please write your questions down, and I'm happy to answer them at the end, or you can email them. I'll provide my contact information at the end. Okay. So let's look at some of the common behaviors after brain injury. This list is certainly not exhaustive, but it's pretty common list of behaviors that we've seen after brain injury. First one is agitation. This can best be described as, quick to anger or annoyance or confusion, motor restlessness. And we have perseveration, which is verbal and or motor repetition. For example, somebody asking repeatedly to go to the bathroom. Then we have noncompliance and refusal. This is typically not following directions, not engaging in tasks, being uncharacteristically obstinate. And there's also a little piece that I've added here about noncompliance and refusal for medication. So we'll talk a little bit about that later. We also have impulsivity, AKA disinhibition, which is quick to act without thinking or of the consequences, or inappropriate verbalizations or touching, whether it be the person themselves or somebody else. We also have verbal aggression, which can be profanities, yelling, name calling, threats. Then we have physical aggression, anything physically against another person, hitting, kicking, shoving, spitting, etc. So we're going to look at these common behaviors. So why do brain injured folks engage in these behaviors, and why is it important to know? It's important to know that all behavior is based on logic, even though it might not seem logical to the observer. To the behavior, it makes perfect sense. Injured or non-injured folks can engage in behavior that could leave others wondering, why are they doing that? Or why did they do that? I'm sure everyone has experienced someone in their life that has engaged in some type of behavior and left you thinking, why did they do that? Like, remember years ago when Britney Spears shaved off all of her hair? Why did she do that? There's always a reason for behavior. For our brain injured folks, some of the reasons may be as a result of impaired communication, receptively or expressively, poor cognition, poor understanding, pain, frustration, fatigue, poor reasoning skills, maybe even a pre-injury personality or emotional distress. Sometimes we may never know what the reason is behind behavior, as we can't get into somebody else's head. But what we can do is take time to get a more in-depth look at the behavior, and perhaps the reasons for it may become more clearer. This is where assessing the behavior comes into play. It's not any kind of sophisticated assessment process, but just a simple 3-step Q&A process. The first step is pinpointing the behavior, asking and answering the question, what is the behavior that the person is actually doing? The second step is observing the behavior to answer questions as to when does the behavior occur, how often, and to what level of intensity does it happen. The third step is answering the question, does the behavior interfere with the person's life, with care, with therapy, with their well-being, and/or does it cause the person or others harm? Why do we want to know this? Because if it doesn't interfere with care or therapy or well-being, or cause the person or other person's harm, then it really doesn't need to be changed or modified. Let's look at each step in more depth. The first step is pinpointing a behavior. Pinpointing a behavior is identifying what the person is doing and what that behavior looks like. For example, I once had a patient, we're going to call him Tom, and each night when staff would come in to shower him, he would wheel himself away from them and wheel himself away from the shower. So pinpointing this behavior would be identifying the behavior as Tom moving himself away in his wheelchair from the shower. The second step would be to observe, perhaps over a few days, and answer the question, when does Tom move himself away and how often, and what is the level of intensity that he's moving himself? Is he casually moving himself out of the way? Or is he at level 10, almost killing himself to get out of the way? In this case, Tom was observed to move himself away anytime that staff came in to shower him. It didn't matter if it was day, night, morning, didn't matter. He would respond the same way. The level of intensity that he was moving himself away was of a more moderate level, as he wasn't hurting himself or anybody else in the process of getting away. The third step would be to answer the question, does the behavior, wheeling himself away from the shower, interfere with doing tasks, therapy, well-being, or cause him or somebody else harm? The answer is yes. If he is allowed to continue to not shower, it could result in offensive odor leading to the alienation of others, not to mention skin infections, itching, fungus, sores even. So we've pinpointed the behavior. We figured out how often it occurs. With Tom, it's every day. The level of intensity is moderate. No one's getting hurt in the process, so it wouldn't be that severe. And that it does interfere and could cause him or other people harm in their daily functioning. So this behavior would need modification. Let's practice another example. Hannah has a TBI and has emerging cognitive function. According to Rancho Los Amigos scale, and is engaging in mild motor restlessness, which appears almost nonstop movement during waking hours. She's able to participate in therapy, able to participate in meal times with assistance, and is sleeping through the night. So let's start pinpointing the behavior. What is Hannah doing? She's engaging in physical movement. The second step is to answer how often she's doing this, and what level of intensity. So she's engaging in physical movement almost nonstop, but not during the night to interfere with her sleep. The level of intensity, again, is moderate. Again, no one's getting hurt in the process. The third step is to answer, does this behavior interfere with a task or doing therapy or her well-being? She's still able to sleep. Does her motor restlessness cause her or anyone else harm? Even though her motor restlessness looks uncomfortable, the answer is no. She does not need that behavior modified. It is okay to allow motor restlessness, as it isn't going to hurt her or anyone else. In fact, it might be soothing to her to expend some of that extra energy that the signals in her brain are producing. Now that we've learned the basics with assessing behavior for change, pinpointing a behavior, identifying when and how frequently it occurs and the intensity of it, and if it needs intervention, we need to look for strategies for change. But first, let's talk about ways to help prevent a behavior from occurring, as it's easier to prevent a behavior from occurring than it is to change it. So we look to many ways that we can use to prevent a behavior. In my years of experience, one of the most common complaints that I hear from folks with brain injury and other disabilities is the lack of respect that they feel they are given. So simply providing and talking to them with respect can have the greatest impact on preventing a behavior from occurring. I see this very often. There's a list of do's and don'ts for behavior management that I have included in the last slides that can be used as a cheat sheet. And if we have time, we'll go over them a little later. But there are a few that, in my experience, particularly with brain injury, have been most helpful. And that's to prevent a behavior from occurring. This is provide a calm, low stimulating environment. Take a few minutes to talk to the person, some rapport building before placing task demands. Use simple language with minimal words. Allow time for processing what is said. Many times when we see somebody or our loved one, we're like, hey Taylor, how are you doing? How was your day? What are you guys up to? In her cognitive processing, she's still at hey Taylor. So that's why we recommend allowing a lot more processing and using simple language. Also, you can provide a choice between two things. This eliminates more distraction, more choices for someone to have to process through. Also, provide a lot of praise. Provide like verbal praise, high fives, thumbs up, any of those. This list is not exhaustive or may not be effective with each person. I recommend being creative when it comes to the individual, as You may know them and know ways to avoid upsetting them. For example, one of our previous residents, we'll call him Bill, was very impulsive, very confused, and a fall risk. He was really not very steady on his feet. He needed staff assistance with his balance, particularly with balance in the restroom. Now, Bill was a farmer, and kind of a man's man, and he did not appreciate staff taking him to the restroom, especially males. Did not like that. So staff got creative, and they knew they needed to be in the bathroom with him and in close proximity to be able to catch him if something were to happen, if he was about to fall. So they asked Bill if it was okay with him if they were in the bathroom washing their hands while he was on the toilet. And Bill agreed. He felt like the attention was off of him doing his business in the bathroom, and it made him feel more comfortable. He also felt like he had some control over the situation. So staff were really creative in finding a way to be close to him for his safety without triggering a behavior. So kudos to them. So let's pause for a quick second. I want to just go back to what we talked about in the introduction, which is the strategies that we're talking about today, that we're bringing up. What type of behaviors are we talking about today? Are these severe behaviors that we're coming up with modifications for, or is it not severe behaviors? Yes, mild to moderate behaviors. That's what we're talking about today. What behaviors need a more specialized person to help with, like behavior analyst or psychologist? Yep, behaviors that are more complex and more serious in nature, such as self-injury or extreme physical aggression, etc., as well as behaviors that are resistant to trial interventions. So good answers there. Good job answering good questions. Very good. So finally, let's look at responding to behaviors and strategies that you can use. Some things we want to keep in mind when modifying maladaptive behaviors. We want to reduce or extinguish the behavior. And whichever strategy we use, we need to be consistent with that strategy for an amount of time, say maybe a week or so, to see if the intervention is effective before trying something else. Many times when you implement an intervention, whatever you're going to use, behaviors increase before they decrease. This is called an extinction burst, and it's very common. I see it almost every time I put a behavior intervention in place with a maladaptive behavior or a behavior that I'd like to decrease. It usually increases before it will decrease. So continue to be consistent with your behavioral response. Some of the most effective strategies to respond to behaviors are to replace, ignore, use first then, pre-teaching, and redirect. Fun fact about redirection, it's actually one of my most favorite responses. But the way redirection is most effective is it has to have meaning to the person that's behaving. For example, if you know that Tom likes hockey, and he particularly likes the Hurricanes, if he is beginning to engage in a maladaptive behavior, interrupting him and redirecting him to something that he prefers, such as talking about the Hurricanes, has more prevalence of getting him off that topic than just trying to interrupt with something else or try to redirect him to something he's not really interested in. So redirection is most effective when it has some type of meaning to the person that you're using it with. So let's go back to the list of common behaviors after brain injury. So we're going to talk a little bit about agitation. Agitation, remember, can be that motor restlessness or that annoyance or starting to see somebody ramp up being upset or aggressive. Responding to these things, provide some calming understanding. Validate what they're going through. I can see that you're angry. I can see that you're becoming upset. Also redirect. Like we used with the last example, redirect to something that's important to them. Hey, let's go look at, their hurricanes schedule. Let's go see when they're playing next. Or change the scenery. Ask them, hey, you know what? Let's go take a walk. Sometimes it's okay to allow agitation to happen if it doesn't hurt the person else. Modifying behavior or learning to regulate behavior is a process after brain injury. Next, we have perseveration. There are two types of perseveration: verbal perseveration and motor perseveration. We talked a little bit about this earlier. How to respond, again, you can redirect, ignore it if it doesn't put the person that's behaving at risk or anybody else at risk, or you can provide a textual prompt. We have a gentleman that asks frequently, I need to go to the bathroom. I need to go to the bathroom. I need to go to the bathroom. So when staff have taken him to the bathroom and they've come out, they've written on a piece of paper using this textual prompt, John went to the bathroom at 1:07. You can carry on with your business or doing the activity, and John starts saying, I need to go to the bathroom. I need to go to the bathroom. You can redirect him back to that piece of paper, that textual prompt that says, John, you just went to the bathroom at 1:05. What time is it now? He says 1:07. Yeah, you're right. It's only 1:07. You just went to the bathroom 2 minutes ago. Pretty sure you don't need to go. It just provides them a little bit of something to help with reference and bringing them back to like the reminder of the time that they just had gone. There's also non-compliance and refusal, particularly in this case with participation. We'll talk a little bit about medication in like 2 minutes, but for participation, it's imperative to build rapport with the person. People will do a lot more for you when they feel you have a genuine vested interest in them. You could also use first then. First we can walk, then we can take a break or listen to music, etc. The important part of the first then is put what activity needs to be done in the first and then follow up with a preferred activity. First we need to, do sit to stands 10 times, then we can listen to music. You can also offer the team approach. A lot of times our folks that have a brain injury and they're recovering really struggle and have some fear with engaging in sit to stands or walking, things like that. Using that encouragement of a team approach helps take all that pressure off of just them. And you can say, let's do it as a team, you and I together. That certainly helps make them feel a lot more comfortable with even attempting it. Also pre-teaching. Let people know what you're going to do before you do it. You know what, Bill? We're going to go into the bathroom. We're going to practice, transfers from your wheelchair to the shower chair. And then, we'll come back out here and we'll have a snack. Letting them know what's going to happen really seems to decrease a lot of the bad behaviors. So here with medications, when people become non-compliant with medications or refusing to take their medications, unfortunately, a lot of our folks with brain injury have issues with memory. It's not uncommon. Sometimes you can say, you know what, I'm just going to come back in a few minutes and try again. And that will be effective because their memory is usually a couple minutes maybe, and they forgot that they just refused to take it. Another way you can approach this is arrange for another person to administer the medication. For example, a male or a female if they prefer male over female, or a novel person. You know, if the janitor can give the med, great. If the person really, enjoys talking with the janitor, then if the janitor has more influence over him, then ask the janitor to give him the medication. I would check with your, the powers that be about stuff like that. Also, ask a family member if you're having trouble with the person taking the medication. See if their loved one or their significant other could administer the medication, just kind of in that moment. Remind them that they asked for it or that they took it yesterday. This has been pretty effective. I've seen when I've told somebody, you just asked for this. I'm just doing what you told me to do. You wanted me to take your medication, so here it is. Or you took it yesterday, and then the person feels like, okay, if I took it yesterday, then it must be okay. Finally, sprinkling in food. This is, something that you would need to check with a physician about, sprinkling in food, because you need in order to have medication sprinkled in food, unless it's your child, which my child took medication, so I didn't have to do this, but I do say that sometimes it's important with some of the other residences that we work with. So keep that in mind. You would just have to ask a physician for an order. Impulsivity and disinhibition. This is being like fidgety and touching, also being sexually inappropriate or engaging in sexually inappropriate statements. How do you respond when someone is, touchy, grabby, feely? I know my daughter has a hard time being impulsive with picking up lint off the table. And my table, unfortunately, has dust on it. So she likes to pick out those little lint pieces off the table. Replacing that, giving her a fidget toy or a spinner or one of those squishy brains helps to keep her hands busy so that she's not engaging in that behavior. Just, simply replacing that. Ignore it if it doesn't put the person at risk of harm or anybody else. Redirect. In this case, you could say, hey, let's go do something else, or let's look at this puzzle. You can also set limits, which, if they're becoming sexually inappropriate, you could say, I'm going to step away for a few minutes if you're going to continue to talk to me like that. You can also say no when you need to. No, inappropriate, and then provide very little attention after that. Next is verbal aggression. How to respond. Really ignore it if it doesn't put the person at risk or anybody else at risk. You can certainly set limits. If you're going to call me names, I'm going to just walk away, or I'm going to go sit over here. You can provide a replacement phrase. You could say, if they're saying, I'm going to kick your ass, you could say, you know what you could say? You could say, I need a break. I really need a break right now. You can also validate, hey, I can see that you're really upset, but we treat each other with respect here. I'm going to give you a few minutes to collect yourself, and then I'll come back and we can move forward. You're not really addressing the verbal aggression or why are you saying that and kind of being confrontational. You're just letting them know, it's not acceptable, and we're going to come back to do something a little bit later. I'm just going to give you some time to just, think about that or rest. Finally, this is one that we didn't talk about a little bit earlier, but I thought about it after the fact. A lot of times we have folks that like to elope, and they're very confused a lot of times, and they're trying to escape and get out of where they are because, it's a very unfamiliar environment to them. So here at Learning Services, we use a lot of reassurance and reorientation. You are safe. You're here at Learning Services in North Carolina. We're all here to help you. You're here to get help with your injury to your brain and make you well. And we really care about you. And we're going to work with you as best as we can. And you're safe. You could also redirect by changing the activity. Hey, let's go for a stroll if they're trying to get out the door. Hey, let's go to the kitchen. Let's go listen to some music. I know you like country music. Let's go listen to some country music. Or you can also offer food or a drink. That usually, redirects me easily, food or drink. So I usually rely on food or drink, when all other things fail. If they're not really interested in anything else, usually folks are pretty interested in getting food or a drink. Physical aggression, how to respond. Block and move out of the way. I know this sounds too simple, but there's been times where I've had staff that don't move out of the way. So just block, move out of the way. You can set limits. Hey, hitting is unacceptable. We don't do that here. Give them breaks. When you see that they're starting to escalate, pull things back. Say, you know what, let's just sit here for a minute. We'll just sit, we can talk, I'll listen, or you can just change the activity and redirect. Hey, let's go see what so-and-so is doing, or let's go check on what the weather looks like today. That usually takes them, off the behavior at hand. So we're going to recap your knowledge just really, really quick. When to get help. Let's look at this video, and I want you to tell me if this person or when they need help. So does this need help? Does it need professional help? Yes. It needs a behavior analyst and their grandma to step in. But really, when do we get help? When more complex or dangerous behaviors are involved, self-injury or extreme aggression, when a person is resistant to behavior change or behavior strategies, you've trialed a few things, they're not really working, or behavior worsens. I know that we talked a little bit about some of the list that I have, and we can go over that real quick. The do's and don'ts. This is a behavior management cheat sheet that you can print and post, or sometimes just leave it on your desk so that you can review it frequently. And it's very simple do's and don'ts. Do speak calmly and softly. Do speak slowly. Do tell the person what you're going to do before you touch them. Do be firm. Do set limits. Ask permission. Use reassurance and reorientation. Change the subject when needed. Change the activity to redirect. Give breaks. Allow restlessness. Provide praise for calm behavior and participation. Ignore it if it doesn't put the person or someone else at risk of harm. Come back and try again later. Give choices. And say no when you need to. So don't yell or raise your voice. Don't show agitation in your voice, an angry tone, fast rate of speech, or show nonverbal agitation. Don't argue. Don't surprise or startle the person. Don't lie or give inaccurate information. Don't have more than one person talking at the same time. Don't restrain the person any more than is absolutely necessary to keep everybody safe. Don't touch the person excessively or unnecessarily. Don't use baby talk or a condescending tone. Don't force it if you have to. Don't talk over the person as if they aren't there. Don't have the person between you and the door. This is a safety factor. Don't be in their personal space any more than necessary. and don't talk about their behavior in front of them, because many times I've noticed that they usually just, it's like a self-fulfilled prophecy that they just automatically start behaving again. So any questions? I know there's a lot of information packed in a very short amount of time.
Thank you, Natalie. Are you finished with your presentation
Yeah.
at this point? Okay, great. All right. Well, we can go ahead and move in then to the Q&A section of the presentation. Thank you so much. That was fantastic information for us, Natalie. We really appreciate the presentation. There are a few questions that have come in already through the Q&A and chat boxes. So I'll go over some of those, but if you have additional questions now, go ahead and type those in, because we do have time to go ahead and try to answer as many questions as possible. First of all, Natalie, one question that came in was, are these strategies specific to working with individuals with brain injury, or are these strategies that can be used more generally for behavior? Do you want to speak?
You can certainly use them more generally. In working in brain injury, I've seen that these strategies seem to be a lot more effective.
Yeah. There was also a question that was sort of kind of trying to get you to speak to, like, when is behavior, and the example that was used, agitation, like when is agitation considered to be acceptable versus problematic and require an intervention?
When it becomes problematic is if it's a danger to the person, if the thrashing or the constant movement is breaking down skin, if they're in a wheelchair and it's rubbing, or if they're hurting themselves in some way. We can redirect some of the agitation when that's typically like a Rancho 4 level of agitation, where a person's just emerging from coma, and they're trying to make sense out of this world again, and things are a little bit scary, and the body and brain are trying to work together to reorganize. When it becomes harmful is when they're hurting themselves, or if they're flipping themselves out of a chair. That's typically when we would rely more on a pharmacologic intervention to help calm them a little bit more, if they need it, or usually just try to redirect that behavior, and sometimes finding things for that person to do, to engage in, to expend some of that energy. I know helping them to walk during that time uses a lot of that energy that the brain is just producing. So typically trying to redirect it, finds like a replacement even, but definitely if they're having some skin breakdown or some issue that way.
Great, thank you. You have a lot of questions coming in, so I'm going to do my best to keep up. Another question that I think is probably a really important one for us from an attendee: would you mind addressing how to best deal with individuals who have a brain injury that consistently make racist or sexual comments in nature?
I would give it very little attention, and I would simply say, I would explain the first time that is inappropriate, and this is why. It could cause issues if you were saying these things out in public, or it could hurt somebody else's feelings, and it's unacceptable to talk like that. And then just remind them inappropriate, for the future frequencies of those behaviors or those statements. I would put that on extinction, meaning I would try to reduce that or extinguish it, try to get rid of it by not really giving it a whole lot of attention. You might need to explain it in the beginning as to why, and then just keep saying inappropriate, inappropriate, and then not really engage the person.
And that ties into another question that popped up, Natalie, related to the use of the word inappropriate. And I'm wondering if that's ever come up for you in other conversations about, whether that word is the best word to use. Can it be interpreted as condescending? Are there alternatives, or why would you choose that word?
I feel like the population that we work with now understands what appropriate and inappropriate is, but I completely get that. If you're working with, say, a child, you could say it's not okay, and pair that with body language at the same time. It's not okay, and that's, nodding your head no. Not okay is probably the most simplest response with a head nod. I think that's pretty universal.
And it sounds like the idea is to keep it clear, so that it's
very clear,
right? And so it's using a word that's not going to be confusing for somebody.
Right.
Very good. Okay, let's see what else we have here. What role does or should medication play in behavioral management?
What role? Was that the question? I'm sorry.
Mm-hmm.
What role? Medication is good when it's needed. When you can provide a behavioral intervention or a strategy like some of the ones that we've talked about, and they are effective, and you can see that it's changing the behavior, it's okay to hold off on looking at pharmacologic interventions. When does a pharmacologic intervention become necessary? Usually the physician would, that you're working with, would say, after you've explained to them, we've tried, this strategy, we've tried this strategy, we've tried this strategy, using some of that pinpointing and that 3-step process that we talked about, pinpointing and looking at how often the behavior occurs, and then, whether or not, it, interferes with the person's life. If it interferes with their life or their care, and that it's not really changing much with the behavior interventions the strategies that you're utilizing, that's probably a good time to discuss with your doctor if there are pharmacologic interventions that could be used, maybe even alongside of the intervention or the strategy.
Great. Next question. Can you speak at all to assessments or interventions that you would use with dually diagnosed brain injury and bipolar disorder?
Well, in what context? Like what would the behavior be?
Well, I'm not sure. I didn't. It was an audience question, but I'm assuming somebody's saying this is an extremely common combination. So maybe, I guess, just us thinking about, like, when you know that the individual has bipolar disorder, would it change any of the strategies or the assessment that you would use in looking at behavior? Go ahead.
Go ahead.
No, I was just going to say, as a psychologist, I would expect that we might see some, in those cases, we may see more explosive behavior, some agitation, that type of thing. Would you look at that situation, assess that situation, or have different strategies for that type of very common dually diagnosed situation?
Some strategies I might use with that would be, videotaping, so they could see before and after of their own behavior. I would use some of the pinpointing as to what triggers the behavior and what purpose does the behavior have with the person. It would also depend on a factor of, is the person medicated? Is this a learned behavior, and how does the person respond to a behavioral intervention? If you've tried something and use it for a while and they're resistant to medication or resistant to the intervention, that's when I would look for more assistance. I'm more of a psychologist or psychiatrist or neuropsychiatrist. But if it's an explosive behavior, that's more of the severe behaviors that, you know,
Or manic behaviors, like if you have folks that are, you know, maybe going through a manic phase, you know, do you look at those differently?
do I look a little bit with that? I would use more of the team approach with more of a professional team. So it's not just the behavior that we're targeting. You know, it's also sleep-wake cycles. We're also looking at, you know, various other things as well.
So it sounds like that requires a more holistic, a more interdisciplinary
approach. Yeah.
When we have those dually diagnosed cases.
But that's a good question.
Yes. Let's see. Another question has come up. Natalie, for quote unquote sharing conversation, what suggestions would you have for interruptions?
For interruptions, okay. Like the person is just interrupting constantly.
I believe so, yes.
So there are a few things that you can use. You can explain about interrupting, what interrupting is, and, you know, there's been times where I've taken data on how many times a person has interrupted me in a conversation and then showed them, this is how many times you interrupted me in this conversation. Do you think maybe I can help you with interrupting? Because it appears to me that you're not able to recognize that you're doing this, and use what I call as a red-green card. So it's just a laminated piece of paper that's red on one side and green on the other, and start working with the person with, you know, red that I'm talking, and so you're not to interrupt, and then just kind of point to that when they start to interrupt, that it's red and you're not supposed to be talking because I'm talking, and then flip it over and it's green, and shaping that behavior by saying, this, now it's your turn to talk. Now it's okay to talk at this point. So you can start training that way as well. That may take a little bit longer of a process because it's more of a shaping behavior, and those are usually a little bit, you know, lengthier than just, you know, interventions, but it works. It's just helping that person realize that they're interrupting.
Great. Let's see, we do have some more questions here coming in. This is a good one. It says, when addressing inappropriate comments, is it best to address it then and there in the moment, or to remove the individuals from the company of others to address the situation?
That's a really good question. If the person does not have the ability to hold on to information, it is okay to gently tell them, and maybe you can do it indiscreetly, that, you know, that whatever that they're saying is rude, or, you know, makes the other person feel uncomfortable, or you can ask them to step away. Sometimes the person, if you ask them to step away, they might not remember what they were just saying, to be able to correct that. So if you can indiscreetly, you know, explain to them or call them out on it, that would be good too. I hate to people talk about behavior in front of them, but if you're doing like a teaching process, and they feel comfortable about it, maybe even do it just with family so that they don't get offended by it, but ignore it if it's in the community, because you are like shaping this behavior and training this behavior. Does that answer your question?
Yeah, I think that's good. And I mean, it sounds like it kind of depends on the situation and the person, right? If they have a memory impairment, or the setting even, would you if you were talking to a family member, would you have the same kind of advice for a family member versus a professional?
Um, like if it was my family member that was, I would probably talk with them and tell them what was wrong about it, because maybe they don't really know that what they're doing is wrong, or make somebody else feel uncomfortable. And then you could also work on signals. I've seen people use signals, like, you know, put it in a finger up and kind of to let the person know that you're going into a touchy subject or a topic that's really not the best conversation to have with this person, or you know, you can find some other way to indicate to that person that that's, you know, not appropriate this time, or, you know, could lead to other issues or problems.
Great, yeah.
If
And
somebody is going to become upset and explosive if you try to correct their behavior, then I would just kind of pull them aside. I would avoid the upsetting them with others around.
great. Another question. Do you have any suggestions specifically for police officers that may be confronted with behaviors?
That's a good question too.
And I'm wondering if this has to, I mean, I read the question verbatim, but you know, I think the idea of, is there important information that police officers should know about brain injury or approaching people, since they may be approaching people where a brain injury is part of the context of the situation?
I do think police officers get training now, but specifically for brain injury, I think it would be best if police officers and EMS folks were trained that sometimes brain injured folks do not interpret facial expressions or the tone of our voice the same way as everybody else, that can be impaired. And like the police officer could say, what's the problem? And the person with the brain injury perceive that as them yelling at them. I would just hope that the police officers would be very calm and speak very slowly and use very neutral body language and facial expressions so as to not trigger somebody. You know, anytime you see a police officer, I mean, I'm not going to lie, it, you know, triggers me just to see a police officer, you know, especially if a police officer is following you. So anytime that you come in contact with somebody, I think it's just a natural response that's a police officer. You might get a little bit more uptight. So having a police officer be more calming, use very neutral body language, facial expressions. A lot of our folks can't interpret facial expressions correctly and appropriately. That's an area of deficit in their brain, and they need training with it. So I would probably say use very open body language, and not be confrontational. Only go, you know, use force if necessary. See if that you can talk to the person and kind of just validate what they're going through and build a little bit rapport.
Great.
Question?
Yeah, great. Okay, I think I've actually gone through the whole question list. So this is sort of last call here for any additional important questions that we want to get Natalie to answer. And as she mentioned as well, if questions do come up, she'd be happy to connect with folks offline to answer questions as well. Natalie, I just want to say thank you again for a fantastic presentation. There's been a lot of comments that have popped up on the chat talking about how helpful the information has been, and people are very happy to have the do and don't checklist that you provided. So just wanted to give you a little bit of that feedback. Thank you very, very much.
It helps.
Yeah. So thanks And Natalie, and for everyone who came and is joining us for this presentation and has been with us throughout the day. I do have a couple of housekeeping things to go over with you here at the end. First of all, we hope that you enjoyed the conference today, day one, and that you will check out the 7 on-demand sessions that are available for viewing at any time of your choosing. Also, if you are seeking credits, then be sure to carefully review the CEC guide to understand how you are seeking credits. Be sure that you complete the evaluations for this conference so that you can obtain your credits appropriately. And last, remember that we reconvene tomorrow morning from 8:30 to 8:50. At which time you're encouraged to visit the exhibitor booths or to drop into one of the networking groups to say a quick hello to the other conference attendees. The opening remarks are going to start promptly at 8:50. And at this time, I hope that everybody has a fantastic evening. Thanks again for joining us today, and we look forward to seeing you all tomorrow. Thank you.